Alrighty, let's just make sure all of this looks good. Let's make sure all of this is correct and stream looks good and sounds good and all that stuff. Once everything sounds good, I think so. I think we're good there. So we're just going to go like this. Make sure that's okay. Let's share this stream on ye old YouTube and Twitter. And once we get to sharing, we will process this and start the show. Almost ready to start the show. Here we go. Okay. Almost ready. Almost there. We are posted, and I think that because we are posted, we are also ready to get going. So, without any further delay, I think that's all we had to do, right? Yep, we're good to go. So good afternoon, everyone. It's good to see you. Glad you're here. I am Dr. Patrick Lockwood, and for the purposes of this podcast, I'm just Patrick, so please don't sue me, fire me, blah, 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 blah. Thank you for coming to this week's episode of UnShrink Me. Thank you to everyone who watches and chats while the stream is happening, to everyone who watches and shares after the fact. Again, thank you so much. For those of you who are brand new, this podcast is a weekly podcast focused on mental health, psychiatry, psychology, and essentially the goal of this podcast, if you're brand new, is actually just to help the consumers, the people who are actively seeking out services from psychiatrists, psychologists, counselors. I want to make sure that everyone has every opportunity to understand what the research actually says, to understand what these fads and these trends are, and to talk about all the things that may be popular and trendy, but which may not be actually good for your mental health and may not actually be helpful in therapy. So the goal of this podcast is to educate and protect the consumers from the profession, because unfortunately, one of the problems with the profession nowadays is there's lots of myths, there's lots of fads, there's lots of nonsense, which we'll talk about today. And unfortunately, people who are struggling, people who are, let's say, vulnerable, to use a word that's popular nowadays, might be put at risk of being hurt by the profession, or on the milder end, probably just not helped. So the purpose of this podcast is just to protect the consumer, inform people, and make sure everyone is okay. And so I really appreciate you all being here, and I hope you understand the spirit with which this podcast is moving forward. There's already some rabble-rousing in the chat right now. There's this scoundrel named Ryan in the chats who said, have you guys heard, this is what he said just now while I'm trying to introduce the podcast. He said, hey, have you guys heard the rumors spread that Patrick skips leg day? I think that it's not true. I think that I actually participate in leg day, and there might even be proof on a platform like Twitter or something like that proves that I, participate in leg day. But, rumors abound. It's a problem this day and age, especially on social media sites. So ignore the rumors, Ryan. Ignore. This podcast is not NOT sponsored by Celsius, but Celsius is awesome stuff. And so it helps me fuel this insane podcast and my camaraderie with my friends here. That's so good. So today's podcast is going to be a little different than prior discussions because we really need to talk about a couple of important topics that don't get the same attention on other podcasts about mental health. So one thing we're going to talk about is affirming care and what it means to affirm something. But we're also going to talk about something that's a little more complicated called being built different. That's a phrase that you hear from therapists and coaches and gurus and things like that on podcasts. So I want to talk about that too. But also I want to talk about what it would mean to actually fix the United States healthcare problems with regard to mental health, which is a little more big picture, but I think it'll still be fun. So we'll do what we can to kind of get the show rolling. And I think before we even get the show rolling, I'd actually like to start with one of my posts. Let me retweet it real quick. Because I think it's actually relevant to some of the conversations we're going to have today. All right, so about 3 days ago, I put out this post that said 3 life-changing questions. Number 1, how useful, in parentheses, for my goals or mental health is my reaction? So number 1, how useful for my mental health or my goals is my reaction? Number 2, what matters most to me? And number 3, what's in my control? If you combine them, and you can overcome most situations. And a good friend of mine who may or may not be on this this podcast is also curious about, how you would actually overcome number 1, because the problem with number 1 is a lot of people are good at rationalizing their, let's say, their emotions, their reactions. And so here's what I would say. And the reason I like this is because one thing that good therapists do is they help you understand your process, right? Because your process is unique to you, right? There's no one way that people function, right? This is something I'll talk about in just a second when I talk about people being built differently. But question number 1 is, how useful is this reaction? Your reaction is not really something you can consciously control, unfortunately. However, what you can control most of the time for most people is what you do when you notice you're having a reaction, right? And then the follow-up question is, what is useful about this reaction? How useful is it to what I'm trying to achieve in my life, right? I think that's a hard one. And I think it's really hard because, like my colleague said, we could justify our feelings. If I'm angry at someone, I can justify my reaction and say it's actually perfectly valid for me to have this reaction, and anything I do because I'm angry is justified, which is absolute bullshit, right? There's a difference between having a feeling and your feeling making sense versus your feeling causing you to do things that are justifiable and useful and good morally. And so it's like you can be angry at somebody, but it's really stupid to use that anger to hurt yourself and other people, right? And so whether your anger comes from trauma, which is a real thing, a lot of people with PTSD have excessive anger reactions. But just because your anger is understandable and justifiable even, doesn't mean your behavior, which is against your values and against the values of society, like punching somebody in the face, that's not justifiable. That's not okay for you or for society. And so number 1 is the harder question. Number 2, what matters most to me? Kind of a straightforward question. Now, sometimes our feelings will color our experience and cause us to misunderstand what's actually the most useful to us. But the truth of the matter is most of us know what our priorities actually are. Family, friends, career, things like that. And number 3, what's in my control? This is a deceptive question because a lot of us believe that we can influence people, which is different than controlling people. But the more important thing is, what about myself is in my control? And that's hard for people. And what I would say is, it's really, really important, if you're in therapy or if you're getting psychiatric services of any kind, that you pay attention to these questions, not because these questions will magically solve anything. These questions are temporary band-aids to give you some time and space before you make a bad or a good decision. But the reason these questions are helpful, other than creating time and space, is it's going to reorient you towards what actually matters in your life. And I think a lot of people will sacrifice long-term vision for their life, especially when they're struggling with mental illnesses. People with bipolar, people with PTSD, people with personality disorders, people with substance use disorders regularly shortchange their long-term interests, their future self needs for their short-term emotional needs. And so it's really, really important for people to take extra care when they're having strong feelings. It's especially important, for people with mental illnesses to be extra careful when they're having a strong emotional reaction and not shortchange their short-term needs for their long-term goals, because you can have a short-term temporary emotional reaction which is completely counter to your long-term needs, especially if you have a mental illness. And so this is how you get people shooting Charlie Kirk. This is how you get people trying to assassinate the president of the United States. This is how you get people doing any kind of stupid fucking thing. And it's really important to make sure that you're really on top of your reactions and your emotions, because you can be the smartest person on the planet, and it doesn't even matter how smart you are. And if you have a strong enough emotional reaction that you can justify, you'll do and give yourself permission to do anything. And so it's really important to be clear that you and all of us are capable of justifying anything that's not good for our well-being. We're all capable of it, and that's why these questions are helpful. Secondarily, maybe even more importantly, it's really important, in my opinion, for therapists to be acutely aware of their motivations, which sometimes therapists are, but oftentimes therapists are not. So therapists of all kinds, so if you're a consumer of therapy or psychiatry out there, it's often the case that your clinicians are not fully aware of their motivations for how they talk to you or why they even choose to use certain interventions with you or not. It's often the case that your clinician is afraid to touch on things with you, for instance. So a lot of patients have difficult emotional experiences or have different political beliefs, which has been a topic we've talked about. And many clinicians are terrified of having a real relationship with you and dealing with these issues in a way that's actually like being an adult and an integrated person. Because again, therapists are people too. Just so everyone's clear. In case you haven't heard me say that before, it's 100% the case that therapists are people too. And because we are all just regular people, sometimes more insightful, sometimes more intelligent, just because we're either more insightful or more intelligent doesn't mean that we're still not just regular people, right? Insight and intelligence doesn't magically protect you from being a regular person. And so it's really important for therapists to think, how useful is my reaction for my goals or my mental health? And also, what matters most to me as a professional in this context, right? And it should be the patient's goals and needs. It shouldn't be my emotions or my reactions as a professional, right? And what's in my control? And a therapist, and this is especially important for you patients out there that hear this, therapists cannot magically change your life for you. And some therapists would like to believe, because of their own personal issues or their own mental health or their own family of origin problems, that they can fix their patients or they can magically solve the family systems problems or they can whatever. Because like therapists often get into this work because they have their own baggage. Often. And so it's very important for therapists to understand that there's only so much we can do to actually help people and support people and encourage people. It's not like we can magically fix people. So we all have to be very clear about our boundaries and our goals with patients. So that's why I like these 3 questions, and I hope they're helpful to you. Number 1, how useful for my goals and my mental health is my reaction? Number 2, what matters most to me? And number 3, what's in my control? These 3 questions are a good beginning framework for managing your internal process so you can more effectively engage with yourself and the world in front of you in the here and now. All right, moving right along to the next topic. There's so many important ones out there. All right, let's have a bit of a spicy one. So I have a consulting practice, full transparency, so you know exactly what my motivations are. I have a consulting practice. I'm a professor, I'm a therapist, I'm a consultant. And so one of the things I do as a consultant is I help people manage and prevent burnout. And so because of that, I'm aware of the things I'm about to say and the potential bias or financial motivations for the things I'm about to say. So please take what I'm about to say with a grain of salt, given my personal financial bias. Okay? So I'm gonna repost something real quick, so you know what I'm talking about. Okie dokie. Hey Darren, glad you're here. I'm glad you're here. Jonathan says that's a really good question. I think number one's a really good question. Yeah. So here's the post I want to talk about currently. So my colleague online, Dr. Ed Perrin at Dr. Doctorperin, Dr. Perrin said on 9/29, stop calling exploitation burnout. So he's making a plea for people to stop describing what is obviously exploitation as people struggling with burnout. And that applies to many types of work settings, education settings, and training settings. And so my post 5 days ago went like this. I said, these things are not remotely the same. Graduate students, med students, healthcare workers generally are not burnt out. They are literally exploited. So let me be clear that what I'm about to say could sound like a pitch for my services or anything like that, and that's not the intention of this. This is just to educate consumers so you understand the context a little more effectively. You know, I'm not seeking out business in this podcast ever. So here's what I've noticed. Here's what I see. And so many of the people that are currently chatting can also probably speak to this too. Many different types of healthcare professions, whether it's nurses, doctors, psychiatrists, psychologists, counselors, etc., are all part of these healthcare systems. And these systems are designed, if you don't know, to find and hire often the cheapest possible labor, especially at the lower levels. So I'm just going to describe a typical example, which is like this. So many people here in Southern California in particular, but it's not unique to Southern California, will go get their master's degree. They'll get their MFT, or they'll get their licensed professional counselor degree or master's in psychology, or their doctorate degree, PsyD, PhD, or get their whatever, their MD. So many people will get their advanced degree so they can become a mental health professional. And so they have to get their hours to get licensed, right? And so the way this works is, the vast majority of people, at least that I'm aware of here in Southern California, will go get their hours to get licensed, because we have to get licensed to build a career as a professional, right? So just talking about psychologists, psychiatrists, and master's level clinicians and counselors, right? Like, in order for us to get our hours to get licensed, because we need to get licensed so we can go build a private practice or whatever our dreams are. But in order for people to get licensed, you have to get 3,000 hours typically of supervised professional experience. So the question is, where do you get your hours, right? And so, the state of California has certain restrictions about where you can get your hours. You can get your hours at like a rehab, which is how a lot of people do it, or a clinic or an IOP, but it's usually not you're going to a private practice and getting 3,000 hours of experience. Usually you're going to go work for a big organization where you can see lots of patients and get your hours in a couple of years, right? And so the way the system is set up is it's set up to exploit people. Specifically, it's set up to exploit interns, pre-licensed professionals who are trying to get their hours. And the same is true for physicians, psychiatrists, doctors of any kind, whatever your specialty. They're literally designed to be exploited in med school, in their residency, and before they get licensed and board certified. And so just describing it for like mental health professionals, just so everyone knows, what happens is you graduate with your degree, you start to collect your hours. And many of your hours have to come from like working at a rehab. And so rehabs are like, okay, how do I save the most money and make the most money? Which is true for most businesses, especially healthcare businesses. And so if I can hire interns who are cheaper, right? So like if a licensed therapist can make $100,000 a year here in Southern California, can a pre-licensed person make $75,000, for instance, right? And so that person is going to do the most work and be on the front line working 40 hours plus a week dealing with patients, 5 to 7 days a week at that drug rehab, trying to be like the front line for crises and see all the patients and do groups. And, they'll do all their required work to get their hours, but also they'll do extra stuff to suit the needs of their employer. Now, some of that's just working in treatment, but also some of that's just like exploitation. And so the people at the lowest end typically do the most work. That's the most grunt-like laborious work in mental health care training. And so by the time they get their 3,000 hours, they have worked their tail off doing 40 plus hours a week of individual therapy, family therapy, group therapy, insane and stupid documentation that no one likes to do, and jumping through hoops and phone calls and crisis management and all these things. And then they finally graduate with their hours and they take these, difficult, licensure exams, and they pay all this money to get licensed. And so that is exploitation. There is a system that is set up to take advantage of these people because they're in a position where they need these things, right? That's not burnout. People will describe themselves as burnt out, and it's colloquially correct. But the truth of the matter is, many people are burnt out before they even graduate or get licensed because they've been exploited for 2 to 4 years, right? And the even bigger problem is, in order to get some of your clinical training hours while you're in graduate school to get your doctorate degree or even your master's degree, you have to go work for free in a traineeship called a practicum before you can even go on your internship and get paid less than a living wage to get your hours. So many people are basically exploited for 4 years before they ever get licensed. So you can think of it like being burnt out, but the truth of the matter is the healthcare system is set up to exploit the people lower on the rung, interns, pre-licensed people, nurses, so on and so forth. And residents in medical school, all these people are literally being exploited. So in the medical literature, when they talk about burnout or whatever, it's kind of funny to me because it's not burnout. It's exploitation. It's people that are not paid a living wage. It's people that are given excessive demands and tasks, which is part of burnout, by the way. But the truth of the matter is it's a different problem. It's like calling depression the same thing as grief, and they're not the same thing. They're both low mood and hopelessness and all these things, but it's not the same thing. So I hope everyone understands that many of the clinicians you see have a history of being exploited. Now, it's voluntary, so we're all choosing it or whatever, but it's exploitation. Now, there's no easy solution to this, but I want you to understand that your therapists have often been exploited before they got their degree, and it's not unusual. And so if they seem burnt out or something or whatever, that's not weird. And it's not that they're necessarily burnt out, though. Darren says, I got at least 3/4 of my hours through voluntary work at community-based organizations. That's awesome. I'm happy to hear that. That's not true for most people, at least here in SoCal. Most people that I'm aware of here mostly get their pre-licensed hours, at a clinic, a rehab, an IOP, a hospital, whatever it is, Like most of for doctorates, for like PsyDs and PhDs, most of them have to go through APIC, the APA internship process, or KPIC here in California. And it's like most of these clinics don't pay you nearly what you need to have a living wage, And I'm not complaining or anything because I've already been there, done that. It's just, it's hard on people. And so many therapists, just so all consumers know, many therapists really did bust their ass in grad school and in their internship to get licensed, or their associateship, or whatever you want to call it, so that they could come do the work that they're doing with you. And so many people will charge a wage that actually helps them not only pay for their loans and stuff like I do, but also allows them to complement what they're actually worth, given all their experience and training, for sure. First Celsius Belch Ryan. It's a new flavor, so there might be fewer belches. Who knows? So, healthcare workers, yes, burnout once they're licensed and in a system that's not meeting their needs. But healthcare workers are also exploited. And there's a difference between exploitation, which is intentional, and systemic with the intent of taking advantage of people who are in a vulnerable position, like interns and stuff like that, which is different than burnout, which is you voluntarily chose to do this thing and it's not a good fit for you, or your boss sucks at managing you, which I can talk at length about if you ever want to hear about. Darren says, good manners are just something that happens to other people. Listen, Darren, this podcast is built on belches, and if you don't like it, you can see the door over there. Okay? So this is just part of the shtick, and if you don't like it, that's okay. I don't judge it. Noman says, what do you notice among these burnout students or practitioners? Do they have large reactions or not? Yeah, I mean, I think I've seen what's described as burnout, which is actually exploitation, as kind of what, most people think of when they think of the colloquial version of burnout. They think of like feeling disenfranchised, feeling like your work isn't very helpful, like you're not making an impact, like you're not doing very good work. And another classic example of exploitation among these healthcare workers is they don't see the point in actually doing the work in the first place. Like a lot of people literally feel like, what's the point of doing this? And so that's a crystal clear sign that you're starting to feel hopeless because you're literally being exploited. Like you have no power is the problem. So that's the things that I've seen in the last 15 years here in SoCal specifically. Darren says, that's me told. Me told? What does that mean? All right. Let's move on. Let's move on to something that's always fun to talk about. Affirmative psychotherapy. Okay. My friend, my colleague, not friend, my acquaintance, colleague, Dr. Jonathan Shedler, always says cool stuff on Twitter. So let me repost what he said the other day. Okie dokie. So the other day, I think literally yesterday, here's what Jonathan said. Jonathan said yesterday, when people come to psychotherapy for real help, they're not looking to be affirmed or validated. They're looking to be understood. Now, let me say a couple of things about that. Here's the truth. Hoorah, Phil. Here's the truth. Good therapy of whatever kind, whatever your orientation, you could be a CBT person, just consumers. There are many different types of theoretical modalities and types of interventions people can use in therapy. But there are also common factors across all types of therapy. So across all types of therapy, an effective therapeutic relationship is key to successful therapy. And one facet of a good relationship is having realistic and clear expectations. So if you're a patient and you're coming into therapy and you're expecting to be affirmed and validated, you might find therapists who are willing to do that. But the question is, how useful is that given your clinical needs and your goals? And so what Jonathan is saying is very clearly that most people who really want therapy are actually looking to be understood. Now, I'm going to split some hairs, and maybe Jonathan would agree or disagree. Maybe some of you agree or disagree, so you let me know. So Jonathan said, when people come to psychotherapy for real help, they're not looking to be affirmed or validated. What I would argue, personally, and some of this is theoretical, but some of this is also practical, I think that there's no more validating experience for people than being understood. That doesn't mean that every time we feel understood, we feel validated. Because sometimes, when you're being seen, when you feel seen by your therapist, it's sometimes actually very painful because maybe you have a lot of shame, for instance. So dear patients, if your therapist is trying to help you see something and feel seen, it might feel bad at first because maybe you're touching on something that's very painful and or shameful. But in that badness is the potential for feeling good and understood and feeling calm. And so it's very important for people to be clear that if the therapeutic relationship is to be effective, we have to be clear about our expectations. And to be understood is more than just an intellectual thing. Some people, when they hear the phrase, I just want to help you feel understood, that's more than just like this cognitive, it's about your mom, it's about your childhood thing. It's more than that. It's more complicated than that. Because for people to feel understood, there has to be a sense of being on the same page between two people. But beyond that, it's also really, really important to have a shared understanding of what is happening between the two people. But there's also got to be a shared emotional experience beyond the cognitive piece of it. So I can understand, right, if I'm your therapist and I'm trying to explain what I believe is something that happened to you as a kid and how it's shaped your perception as an adult, that's a cognitive thing. But the emotional piece of it is you had this set of experiences that left you feeling helpless or powerless, just to name an example. And right now, as we're talking, the question in your brain might be, do I feel empowered by what this man is saying to me? Is he trying to help me feel empowered? Or is he trying to help me feel disempowered? Is he talking down to me? Do I believe he's talking down to me? Or do I feel like he's talking down to me, for instance? Because if the filters my brain has is authority figures talk down to me because that's how my dad was or that's how my mom was, then you might have that experience even though that's not what the therapist is trying to do. So you have to work through that. You have to have a discussion about what you're experiencing with the therapist. That's intersubjectivity in a kind of technical transference, countertransference sense. So it's really important to be understood and feel understood. We also have to sometimes work through a misunderstanding of one another in therapy. In fact, often, not all the time, but often it's the case that people work through a misunderstanding and feel 10 times more understood after the fact in therapy. Those impasses or ruptures in therapy are a big part of how we get back on the same page and actually get better together, right? Let me go back to the comments here because I think I've made my point there. Darren says, validation is not the same thing as being colluded with. It's feeling heard, acknowledged, and understood. Yes, to Darren's point, collusion is not the same thing as feeling heard, acknowledged, and understood. I can help you as a professional. Dear consumers of therapy, let me say this extremely clearly. As a professional, I can help you momentarily in this moment feel understood without agreeing with or validating your choices. So I can help you understand your choices without saying they're good choices or bad choices. That's collusion. The moment I put a judgment on those things or be directive, like you should or shouldn't, or you should like or not like the moment that comes out of my mouth, I'm now colluding with you. But if I'm just saying, I heard you, it sounds like you feel very helpless or powerless. Like just to give an easy example, I'm angry at so-and-so, so I yelled at them. I've heard this from patients many times in my life because I deal a lot with anger in my practice. And so it's like, I can help you feel understood about the reasons for your anger and the process. And I can acknowledge the pain and hurt and helplessness that drove your anger and your behavior that's not good for your goals. But I don't have to agree with your choices or disagree with your choices when you're angry. Those are different things. That's collusion. It's my job to ask questions. It's a good therapist's job to ask questions and be curious and understanding about why you made those choices and how those choices are good for your goals and your values and your principles and your needs as a person, right? Phil Bradley says, love is true understanding. Absolutely. In fact, some therapists are the most loving people on the planet because all they care about in therapy with you is just understanding, not directing you, not enabling you, not colluding with you, just helping you feel understood and understanding yourself better. Like if you think about, just to be all developmental psychology about it, early infants, so ages 0 to 1 or whatever, infants don't have complicated language, complicated thoughts, and complicated feelings. Infants feel loved and safe and understood when parents do their best to help the infant feel understood by making simple sounds and noises, by trying to mirror, by trying to feed, to soothe, to rock, to play. That is true love. True love is the ability to help someone feel understood. And so good therapy is loving in the existential sense, not in the romantic or whatever sense, just to be clear. And it's really important that we are not affirming or colluding or validating at the expense of understanding. So where I disagree with Jonathan is that there's no need for affirming. And what I would argue, and maybe this is just my bias, and so anyone out there is perfectly welcome to argue back. If we look at what affirming is meant to be, affirming is meant to be some kind of validating of where you are currently at, right? Who you currently are. And so I think there's a lot of space in good therapy for affirming as a temporary experience, not as a primary focus or an end goal. So what I will tell you is that there's the pathological version of affirming, which most people relate to like the LGBT community or whatever. But, to affirm is not really a pathological experience, if that makes sense, because I think it's how it's used or what it's meant to be. Right? So like a classic dictionary definition of affirm is to state something as a fact, to assert strongly and publicly, or to offer support or encouragement. So when I think of affirming in psychotherapy, I don't think of affirming as saying, oh my God, you're the best, this, that, or the other. Nothing superlative or collusional. I think affirming is right now, you're in this state. This is who you currently are, and it's okay to currently be in this state. Which is different than you have to be something amazing. You'll always be this thing. It's like, that's not true at all. Right? And the moment we make this about a specific group, it just gets super messy. So let me make it super messy. So like affirmative healthcare is almost always related to LGBT folks, especially trans folks. And the political version of it's absolutely bullshit and not therapy. That's not therapy. Because a therapist who says, I know you are this and you will always be this is full of shit. Because as a therapist and as a professor, I don't know who you're going to be. I'm a decently smart person. I don't know who you're going to be. I couldn't tell you. I used to run an LGBT-only rehab here in SoCal, and I never once said, you're always going to be trans or this or that or the other, because I don't fucking know. I can't know. It's impossible to know. It's literally impossible to know, right? So when I'm affirming people, I'm offering encouragement about where they are currently at and their capacity to feel better. That's what I'm offering. And so I'm pro-encouragement, I'm pro-validation, and I'm pro-affirmation in a strategic and limited way. I am not pro-affirmation as a panacea to all negative emotions or some crap like that, because that is enabling and collusion, as Darren described it in his comment earlier. But I will help you feel understood as a therapist. It's important that all therapists help you feel understood. It's important that all therapists help you feel encouraged, because part of good therapy is encouragement. It's not like you're a life coach as a therapist where you're always encouraging people no matter what, and it's toxic positivity, because that's disgusting and gross and not realistic. If you're using encouragement in a clinical way, it's based upon a specific set of variables that dictate the type of encouragement. Right? So I've worked most of my life in a lovely place called Rehabistan. And in Rehabistan, a lot of people with serious drug problems we call addictions have had a lack of encouragement in their life. They've had enabling, they've had collusion, they've had grandiose enmeshment with romantic partners and families, but they haven't had actual encouragement in their life. So for instance, when I have patients in the rehab setting who are like, I don't think I can make it through these cravings right now. I'm happy to provide encouragement, which is, I believe you can for X, Y, and Z reasons because I've seen all this proof that you can before. That's encouragement. I've seen you do it before. You can certainly do it now. 100%. And that's not pathological. Now, the question is, do you want to make it through these cravings or not? That's a personal question that only the patient can answer. But certainly you can. You are capable, 100%. Noman says, what if as a therapist you have a patient who continues to cross boundaries and relying on you emotionally? That's when validating and affirming becomes unhelpful. Absolutely, for sure. It's really, really important that therapists, dear consumers of therapy, you hear this very clearly. It's very important that you as the therapist are 100% on top of the boundaries in the relationship. It is your ethical and legal responsibility to be paying very close attention to the boundaries and the dynamics of your therapeutic relationship. So just to name an easy example, if you're a therapist and you have a crystal clear boundary that patients are not to contact you unless it's a crisis between sessions, and you violate that boundary, that is on you, for instance, and you're setting up an emotional dependency. Now, there are actually different types of relationships therapists have with texting, depending upon the setting and the context and the culture, right? So in some clinical settings, licensed therapists might allow texting in between sessions to discuss logistics or whatever it is. And that's a boundary, but it stays at logistics in those examples I just gave. And if it talks about emotions or anything else like that, you're now crossing a boundary. So you have to have a crystal clear structure, a frame to be dynamic about it for your therapy. And if you violate that structure, then you're the one who is enabling your patient to collude. And you're colluding with them for the sake of probably some unmet need. The number one reason therapists collude with their patients is either projection, like projective identification on behalf of the patient, or because the therapist has unmet needs that they're trying to get met with the patient, right? So the number one reason, thank you, Jonathan. Nice belt, she says, thank you. The number one reason that patients and therapists collude together, have a problematic dynamic together, is either because projection, or, more importantly, because the therapist has unmet needs that they're trying to get met with the patient. That happens all the time. Sometimes it happens in very mild and very light ways, and it's not a huge deal. Also, sometimes it happens in very problematic, enabling ways. Jonathan says, affirmation can be great as long as it doesn't create massive, unquestionable taboos that prevent non-judgmental exploration of patient experiences. I think that's a super deep thing you just said, Jonathan, because importantly, if your affirmations, as you said, create massive taboos, unquestionable taboos, it's like, you're amazing, right? If a therapist, by the way, dear consumers of therapy, if your therapist ever uses superlatives with you, you should be at least questioning how healthy and competent your therapist is. Because if they're idealizing you, that's bad. That's almost always bad. It's almost always a problem. A therapist might be affirming like, wow, that was really tough what you went through. I see how capable you are. I see how strong you are, etc. Which is different than you are the best. You are the most amazing, whatever, superlative bullshit. That creates what Jonathan said, which is a massive, unquestionable taboo. Because once the therapist says, as an authority figure, as a professional, wow, you're amazing, then the consequence of saying that phrase, wow, you're amazing, to the patient is now, anytime you're not amazing, it's taboo. Because the expectation is now, show me how good you are, basically, in therapy. And so therapists should never use superlatives with people. I'm not typically a black and white kind of person, an all or nothing kind of person. What I will tell you very clearly is that most of therapy is gray. Some things are black and white. So you're never going to sleep with the patient. That's terrible and bad. Your therapist should never flirt with you. I think compliments are borderline, especially if there's a gender difference or a sexual attraction difference or whatever. Like, that is never okay, basically. And they should also never be extra affirmative or anything like that, because it will create this idealized state of the relationship that's not usually healthy. It's usually serving some need of the therapist, unfortunately, and it's colluding with you, the patient, right? Because many times, just like a little inside baseball here, most therapists don't come from the best families and early relational experiences. So a lot of therapists, they come into therapy because they have some shit they haven't dealt with. And so unfortunately, because a lot of therapists come into therapy because therapists aren't very well put together themselves, what happens is they often are trying to get those needs met with patients, and they don't know it. I'm going to say this one more time very clearly. Many therapists, not all, however, a large enough number of them that it should be concerning, are therapists because they have unmet needs themselves, and they're trying to get those needs met with patients. And so that's a problem, which requires supervision and consultation. I love being a supervisor. I love being a consultant. One of my favorite things is walking a supervisee through a problem that relates to the supervisee's countertransference or their unmet needs. I do it on a weekly basis, and it's so much fun. And so you can find a good supervisor who, if you're an intern, or if you're a pre-licensed person out there, you can find a good supervisor or even a consulting clinician to help you walk through your issues in the way that they're not helping your patients. If you're getting your needs met with a patient, that's a problem. It's not that you, and just so everyone's clear, I'm not saying therapists have to be perfect. I'm not saying therapists have to be healed. I'm not saying therapists have to be amazingly integrated and super insightful. I'm simply saying that there's a reality which a lot of people don't understand. A lot of therapists are not very well integrated, not very emotionally mature, and they badly need their own work or at least a good supervisor. And so it is your job as a clinician, ethically speaking, per the ethics code, to actually deal with those things so they don't interfere with your therapy. A couple of questions here. Gregory asks or says, which is why it's so important for therapists to get their own therapy. Absolutely. I think one of the best things a new therapist can do is go get their own therapy and figure their stuff out. For sure. Jardam says, can you define countertransference and give an example of it? Thanks. 100%. Easy. So, countertransference, now I'm going to give you the broadest definition because some schools of thought have more narrow definitions that are like specific and precise. I'm going to give you a broad definition so everyone can understand it. So, countertransference is when the therapist, the professional, has emotions, expectations, or beliefs about the patient that aren't realistic based upon what the patient is telling you. So those emotions and expectations and beliefs and reactions are about the therapist's personal experiences and the way that the patient is triggering those experiences inside of the therapist. So I'll just give you a concrete example of it. If I am, at my age, treating an older person, right? If I'm treating an older male, right? So I'm 37. If I'm treating a 60-something-year-old, there's a really good chance that I will have a countertransference reaction to that 67-year-old as if it's my dad I'm talking to. So that older male represents to me male authority figure that I grew up with, which is my dad, right? So if I'm listening to my patient talk, my older male patient who reminds me of my dad in some maybe vague ways or very specific ways, but if I'm listening to that older male patient of mine talk, and I start to notice I'm having reactions to him as if he were like my dad, that's a countertransference reaction, right? Does that make sense, Jardam? Did that check out to you? So it could be something as vague as like, I kind of really like this older male because he reminds me of my dad. Or it could be something very super specific. So the vague version is, I really like this guy because he reminds me of my dad. Or it could be something very, very specific, like this guy is talking about this topic, which reminds me of the exact way that my dad talked about this topic, and now I have a strong emotional reaction. I'm glad you understand. Good. Darren says, Many therapists discuss vicarious trauma, but few discuss vicarious healing. Oh, well, that's a hell of a topic for a different day for sure. Will you tweet at me, Darren, and tell me to talk about that next week? Because I think that's a phenomenal topic. Like vicarious healing, what is healing? Even like what is healing? That's a great topic. Noman says, do you think there are many people who should not become therapists? Can we prevent them from entering their profession if possible? So to go back to question 1, are there many people who should not become therapists? I don't think there are many people. I think there are some people who should not become therapists. And so on what basis would I rule people out or like exclude people from therapy? Thank you, Darren. So for instance, the question would be like, what are the criteria for a good therapist? And what are the criteria for a therapist who might more likely do harm? So one thing kind of across the board, if you are generally a not very insightful person, or if you're just not open to looking at yourself much at all, you probably shouldn't be a therapist ever. You should never be a therapist of any kind, whether you're a medical doctor, psychiatrist, psychologist, MFT, LPCC, LCSW, counselor, coach. If you are not interested in improving yourself and taking a look at the ways in which you function, you should not be a therapist. I think across the board. A second thing is if you are not very interested in ethics, you shouldn't be a therapist, which might seem weird, but let me explain. So part of how good therapists work is they have a strong ethical code that guides their behavior and helps them determine the therapeutic frame, right? Because if you don't care about ethics very much, if you're kind of antisocial to the extent that ethics don't matter to you at all or very little, you should probably go into like sales, or you should probably go into some other trade where that doesn't matter, right? So I think if you have no interest in insight or very little interest in insight, if you have no real strong relationship with ethics, you shouldn't be in the profession. Also, I think if you're not very smart, you shouldn't be a therapist. If you're like lower IQ, 90 and below, probably not going to make a great therapist, because some of the more complicated things that people are trying to work on in therapy require a lot of processing power. Like the ability to pay attention to your reactions while the patient is talking, but still keep most of your energy and attention on the patient to notice effectively is hard to do if you're cognitively limited, right? So I think if you're cognitively limited, I think if your mental illnesses are very severe, if you have a very severe drug problem, if you have a severe mental illness and you can't manage it, you shouldn't be a therapist, right? It doesn't matter. It doesn't matter if you're a good person, a bad person, whatever. Like, I don't care what your background is. I don't care what your politics are. I don't care what your morals are. If you are too sick to actually take care of yourself, you shouldn't be a therapist. So I think those are the kinds of things that I would kind of like create as like limiting criteria. Now, how you objectively assess for those things is tricky. You can do interviews with people in grad school. You can use standardized measures for like insight and boundaries and mental health, but that's kind of prejudicial. So it's kind of tricky. So how do we prevent this? You have to have healthier people on the admissions side of graduate schools. That's how we prevent unhealthy people from getting into therapy. Yeah, one problem that Jonathan's bringing up is one of the big problems nowadays with all these training schools and institutes, there's a lot of online schools. There's also a lot of like for-profit schools, unfortunately, that are more like degree mills, and they're not really interested in the quality of the students. They're interested in getting butts in seats and making money off of student loans parasitically from the government. And so I think one safeguarding mechanism is making sure you have an in-person program to the extent that it's possible. Jonathan also just said something I completely agree with, which is the faculty level of awareness of their student strengths and weaknesses is just different in an online program compared to an in-person program, which I completely agree with, Jonathan. Like, one of the great joys of my life is being a professor in the Graduate School of Psychology for my university. And I've done it for years now, and I love teaching, and I love supervising and mentoring people and sitting on their dissertation committees and all these things. And One of my ethical and existential responsibilities is making sure that that student I'm working with is as healthy as possible. Not in the I'm their therapist sense, but I'm their mentor, their professor mentor kind of sense, so that they can go out there and do good work and take care of themselves and be good psychologists. So I think it's faculty level of awareness and accountability to program rules and ethics. And like, I'm very blessed, literally, to be in the school that I'm in and be a professor for that school, because I have excellent colleagues. I have some of the best colleagues on the planet, in my opinion. And they're good people. And they try and they care and they have high standards for the people they admit into their program. I love my school, for sure. Noman says, have you met sick therapists or therapists who were very sick but have healed? Yes, I've met both. Yeah, I've met very sick therapists. They exist. And some of them just function and have like a little niche that they occupy and sort of help people, but often hurt people. But then there's also therapists who are sick but get help, right? So there's some famous examples of people who are therapists who have gotten sick but gotten help. Probably the most famous example of this is Marsha Linehan, the person who created DBT. Marsha has this horrific story, which she has talked about for years publicly, about her own experiences with her own personality difficulties, which led her to get her doctorate degree and create her own new set of like therapeutic skills to help her. And she recovered and got better and started to help lots of millions of people, you know? And so there are lots of success stories. And, you know, the thing I say all the time, which I think my colleague Dr. Perrin doesn't agree with, but some of the healthiest and most successful therapists we will never hear about. I think the healthiest people and the most successful people, the therapists who just kind of had their own issues and became good therapists and got over their own stuff and healed or are healing, those people are just quietly doing good work all across the world. And you'll never hear about them. They'll never make the news. They'll never have an Instagram channel. They'll never have a YouTube channel like me. You know what I mean? Like, so I think some of the best therapists, the best practitioners, are the people who are just like doing their thing out there in the world, living very good lives, and just doing their thing, taking care of themselves and taking care of patients as they should ethically. And we'll never hear about them. That's not to say that those of us online in the public sphere are like wildly pathological. I'm pretty messed up, but I'm like aware of it and doing something about it. But most people are not, right, in the public sphere. So what I would say is, it's really important to be clear that a lot of people doing the good work, you'll never hear about them. They're just good people living their lives doing cool shit. Noman says, have you had sick students and how do you address them when you flag them? I've had a few very sick students, and some of them I've talked to the department about, and the department has tried to intervene with like a student, correction, professionalism plan or whatever. Sometimes people get kicked out of grad school. Sometimes grad school just weeds them out to begin with. I've never had a student who is so sick that they weren't workable. And so my experience is most people that I've been able to work with at my university are workable. They just need some help, some time, some attention, some mentorship, some supervision, and they can kind of grow and get better and do better and take better care of themselves and become more competent, more ethical and things like that. It happens all the time. So, I say we should be super optimistic about the mental health profession because millions of good people are out there doing the work, I would say. Or if not millions, hundreds of thousands of good people out there are doing the work, and you'll never hear about them. They'll never be Twitter famous. They'll never be Jordan Peterson. They'll never be me or whatever. Like the people seeking public attention and trying to make a public approach, that's not the average good therapist. We are not the average. We're the above average, or we're the outliers for good or bad reasons, depending upon who we are. So they're out there, and I would be optimistic that more and more people are out there that are just doing good work and are trying to be non-judgmental, ethical, have good boundaries, not collude with their patients, seek out supervision and consultation. They're out there. So please don't fret be optimistic. I'm optimistic about the profession. I'm on the front lines seeing perfectly good clinicians graduate and go get their license and do good things. So I'm optimistic. And I'm in Southern California where all sorts of bad stuff happens all the time. So I'm here to be optimistic because I think it will get better, and I think it is getting better for sure. All right, folks, it is the end of our time. It's been an hour. I'm cooked. There's so much more to talk about. We got to talk about what's good professional training. We got to talk about that topic that Darren's going to kind of come at me about, like vicarious healing and what healing looks like. We'll talk about that next week. But I really appreciate you being here and chatting with me and having fun and adding to the conversation and prompting me and pushing on me and challenging me and asking questions. This is awesome. I would love to do this every week with you. I will be here every week. I would love to have you here every week. Thank you so much for being here. And if you think anything that was said today was helpful, if you believe that something I said could be helpful to someone you know, please share this with somebody, because there are many people out there who need therapy who aren't getting it because they're unaware of what it looks like to have a good therapist, or what it means to be taken care of ethically and appropriately, or just they're confused or concerned. And if anyone needs help finding a professional, I'll try to find you a professional if you want. I'm happy to take requests and talk to my colleagues in different states if you're in a different state and help you find good care. So please send this to as many people as you think could help. And please like, share, and subscribe so that I can kind of build this and build an audience and things like that. And I will definitely see you next week at the same time, roughly in the same place. Maybe the chair will be over here or over here, who knows. And as always, I like to end my podcast with a joke of some kind, so that's what we'll be doing here today. So I once had this patient who was terrified of trees. He had a phobia of trees and never wanted to be around trees, especially during the daytime. And I couldn't understand it for the life of me. It was very confusing, and because there's spiders are scary, heights are scary, planes are scary. I get all that stuff, but trees, it didn't make any sense to me. So I had to ask him. I'm like, dude, what is the issue with trees? When did this happen? What's going on? Why are you so afraid of trees? And he looked me dead in the eye and he said, because trees are super shady. All right, you have a good week. You have a good month. You take good care of yourselves. Welcome to October. I hope all is well in your life. Eat good food. Have good sex. Laugh a lot. Take good care of yourself, your friends, your family. And I will see you next week. I hope all is well. Goodbye.